All right, welcome to The Explainer. Today we're doing a really deep clinical dive into a virus that has shaped modern medicine, the Human Immunodeficiency Virus, or HIV. So how does it do it? How does a single virus so methodically take apart the human immune system? That's the core question we're going to tackle. We'll get into the nitty-gritty of how the virus works, how we find it, how we fight it, and, what challenges are still on the horizon, even with all the incredible treatments we have now? Okay, so here's our game plan. We'll start with the disease itself, its pathogenesis. Then we'll walk through diagnosis, treatment, and of course, prevention. After that, we'll cover some really important complications and pull it all together with a case study at the end.
All right, let's dive right in. Section 1, the disease itself. You know the saying, know your enemy? Well, to get a handle on this fight, we first have to understand the attacker.
So what exactly is HIV? It's a type of retrovirus called a lentovirus. And there are two main players here, HIV-1, which is the one we see globally, and the less common HIV-2. The really critical thing to grasp is its tropism, its preference for a very specific target, our CD4 T helper cells. Now, you can think of these T cells as the generals of our immune army. And by taking them out, HIV just systematically dismantles our defenses, which is what eventually leads to Acquired Immunodeficiency Syndrome, or AIDS. Now, if left untreated, the timeline for this disease can be all over the map. There's this initial acute phase, and then the virus can just go quiet for years, sometimes more than a decade. But what's really fascinating here is the age factor. If you look at the data, someone infected in their late teens or early 20s might have a median of about 11 years before AIDS develops. But for someone infected in their late 40s or 50s, that timeline can shrink to less than 8 years. It really just goes to show you how complex the dance is between the virus and the host's immune system. And this leads to a huge challenge in diagnosis. The early symptoms, look at them. Fever, fatigue, muscle aches. Sounds a lot like the flu, right? Somewhere between 65 and 95% of people will get this acute retroviral syndrome. But because it looks so much like any other bug going around, it can really delay someone from thinking, hey, maybe I should get tested for HIV. Which, of course, brings us right to our next topic. How do we actually diagnose it? With those early symptoms being so vague, having a really precise and, more importantly, an early way to detect the virus is it's absolutely crucial. Not just for the individual patient, but for public health as a whole. Okay, so when we talk about testing, the real game changer has been the evolution of the tests themselves. A third-generation test, a rapid test, is looking only for your body's antibodies to the virus. The problem? It takes time for those to build up, creating a window period where you could be infected but test negative. But the fourth-generation test, the combo test, is smarter. It looks for both the antibodies and a piece of the virus itself, the P24 antigen, which shows up much earlier. This is huge because it dramatically shrinks that window period, letting us catch the infection in that acute phase when a person is most infectious. So, the modern diagnostic algorithm looks something like this. Step 1, you start with that fourth-generation combo test. But what if it's negative and you still have a really high suspicion, say a known exposure? Well, that's when you go to step 2. You test directly for the virus's genetic material with an HIV RNA test. And then, for the final confirmation, you'll use a specific assay, traditionally this was the Western blot, to be absolutely sure. All right, diagnosis confirmed. Let's talk about treatment. And honestly, this is where one of the greatest success stories in all of modern medicine unfolds. The arrival of combination antiretroviral therapy, or CART, completely changed the game. It took what was once a death sentence and turned it into a manageable chronic condition. And at the heart of modern treatment is this incredibly powerful message. Undetectable equals untransmittable. You equals you. This isn't just a slogan. It's a scientific fact backed by massive clinical trials. What it means is that when treatment gets someone's viral load so low that standard tests can't find it, they cannot sexually transmit the virus to a partner. The impact of this on stigma, on quality of life, on public health, it's just impossible to overstate. So how does CART work so well? Well, its genius lies in attacking the virus from multiple angles at the same time. A standard regimen won't just use one drug. It'll combine drugs from different classes.
You might have an integrase inhibitor paired with a couple of reverse transcriptase inhibitors, for example. By hitting different parts of the virus's life cycle at once, you build this really high wall that the virus can't easily climb over through mutation. It's a multi-pronged attack that leads to durable, long-term suppression. And this combination approach is absolutely necessary because HIV is, well, it's a sloppy copier. Its main replication enzyme, reverse transcriptase, makes a ton of mistakes. And those mistakes are mutations, which is how you get drug resistance. You could almost say it's a smart virus. If only it would apply that intellect to something a bit more productive, like, say, solving climate change. But treatment isn't just about fighting the virus. It's also about protecting what's left of the immune system. We keep a very close eye on that CD4 count, the number of those T helper cells. And there's a magic number we worry about, 200. When the count drops below 200 cells per cubic millimeter, the patient is considered to have AIDS, and the risk for all sorts of nasty, opportunistic infections just skyrockets. That's the point where we have to start them on preventative medications, what we call prophylaxis. And this prophylaxis is very targeted. We know which bugs are likely to cause trouble at which level of immune damage. For instance, once you're under that 200 CD4 mark, daily cotrimoxazole is standard to prevent two big ones, pneumocystis pneumonia, or PJP, and toxoplasmosis. Now, that's very different from treating an active infection. If a patient develops, say, a bad case of shingles, that's varicella zoster, we're not talking about a daily pill anymore. We're talking aggressive IV therapy, like a cyclovir. And that's a perfect segue into our next section, prevention on a bigger scale. Because stopping the virus before it even gets a foothold, well, that takes a whole toolbox. It's a layered strategy that mixes public health education with some really potent biomedical interventions. And two of the biggest tools in that box are PEP and PrEP. It's so important to get the difference here. Think of PEP, post-exposure prophylaxis, as the morning after pill for HIV. It's for emergencies. You take it for 4 weeks after a high-risk exposure to stop the virus from taking hold. PrEP, pre-exposure prophylaxis, is the opposite. It's proactive. It's a medication that people at high risk take before any potential exposure to protect themselves from getting infected in the first place. But tools like PrEP and PEP don't exist in a vacuum. They're just one part of a much bigger combination prevention strategy. You have to layer it all together. You have the biomedical side, sure, but you also need behavioral things like consistent condom use and regular testing. You need powerful public health messages like U equals U. And you need systemic protections built into the healthcare system, like partner notification services, screening our blood supply, and safe needle programs. Okay, so even with all these amazing advances in treatment and prevention, things can still get complicated. And the complications can come from two different directions. From the virus itself, if the disease is advanced, or, and this is the really interesting part, sometimes from the treatment itself. Yeah, let's talk about one of the most counterintuitive and fascinating complications out there. IRIS, or Immune Reconstitution Inflammatory Syndrome. Just picture this. You have a patient who's very sick. You start them on these life-saving drugs, their immune system starts coming back online, and then all of a sudden, they get much, much sicker. It looks like the treatment is failing, but it's not. It's actually the opposite. It's the patient's newly revived immune system suddenly seeing an old infection that was lurking in the background and launching an all-out war against it. And IRIS comes in two main flavors. There's paradoxical IRIS. This is where a known and treated infection like TB suddenly flares up and gets worse after you start the HIV meds. Then there's unmasking IRIS, which is when an infection that was completely hidden, totally subclinical, suddenly gets unmasked and becomes apparent for the first time as the immune system wakes up. And let me tell you, figuring out if you're dealing with IRIS versus, say, drug resistance or a brand new infection, that is a massive clinical headache. Okay, so let's try to pull all of this together. Nothing does that better than a real-world scenario. So let's walk through a quick clinical case. So here's the setup. You have a patient with a dangerously low CD4 count, just 45. They also have a known case of pulmonary TB. You start them on combination antiretroviral therapy. 2 weeks go by, and their fever spikes. A new chest x-ray shows their lung lesions are actually getting bigger. So what on earth is going on here? Is the treatment failing? No. This is a textbook classic presentation of paradoxical IRIS. All the risk factors are lined up perfectly.
the profoundly low CD4 count to start, a high burden of an existing infection, TB in this case, and starting the HIV therapy so soon after the TB therapy. It's a perfect storm for an over-the-top reaction from the recovering immune system. And that case really brings us to a final, bigger question. Now that our treatments have turned HIV into a chronic, manageable condition, has the entire focus of the field shifted? Have we moved past the pure virology and into the much messier world of long-term care? Are the biggest challenges now managing things like heart disease, kidney problems, all these non-infectious issues driven by years of low-level inflammation? Are we now just learning how to manage the process of aging with a virus that never truly goes away? I think how we answer that is going to define the entire next chapter of HIV medicine. Thanks for joining me for this explainer.